If you're pregnant and your recent ultrasound shows polyhydramnios, what does it mean? This means that there is increased amount of amniotic fluid surrounding your growing baby in the uterus. Now, why does polyhydramnios happen? Why do some women show polyhydramnios while others women do not develop it? Now, like in my previous video, I've already told you that amniotic fluid after 16th week of pregnancy is mainly formed by the fetal urine. So, there are two main pathologies which lead to polyhydramnios. The first is that if the baby is not able to swallow the amniotic fluid. Now the baby is producing the amniotic fluid and then the baby swallows this amniotic fluid which is absorbed in the blood of the baby and then again it passes out as baby's urine. So this is what is normally happening in a normal pregnancy. But if the baby is not able to swallow this fluid for any reason, then it would lead to increased amniotic fluid or polyhydramnios. So the most common cause for this is congenital anomalies. So if there is anomaly in the baby which prevents the baby from swallowing, so it could be a tumor on the neck which presses on the food pipe of the baby. Or if the food pipe of the baby is not developed properly, something like cleft lip or cleft palate, so that the baby can't swallow. Or there might be an obstruction in the intestinal tract of the baby. This obstruction can be at the level of esophagus, which we call as esophageal atresia. There can be an obstruction lower down in the GI tract, like duodenal atresia. There can be diaphragmatic hernia. So all these anomalies would decrease the swallowing of the baby. Then now for swallowing, the baby would need a normal neuromuscular function. But if because of any CNS or any lesion in the CNS of the baby, if the baby is not able to swallow because of a problem in the muscle or nerve, then again this would lead to polyhydramnios. And this is seen in myotonic dysplasias or dystrophies. Then another common cause can be genetic abnormalities of the baby, especially trisomy 21 or Down syndrome, or trisomy 18, which we also call as Edwards syndrome. In these two genetic abnormalities also, polyhydramnios is seen to be associated with them. Now the second main pathology is that the baby is able to swallow the amniotic fluid, but it is producing more urine. So when is this seen? The most commonly condition associated with increased fetal urine production is maternal diabetes. So if the mother has gestational diabetes and her sugars are not well controlled, then the glucose from the mother's blood goes to the fetal blood, and increased blood glucose in the fetal blood then leads to more urine production by the baby's kidneys. Another reason can be if the baby is macrosomic or the weight of the baby is more. So a big baby generally produces more urine. Now also if the growing baby goes into high output cardiac failure, which can happen if the baby is anemic inside. So heart failure would lead to increased urine production from the baby. Now you'll be wondering, how can a baby who is growing inside the uterus develop anemia? So this is mainly seen in two important conditions. One is maternal isoimmunization. This happens if the mother's blood group is negative and the blood group of the baby is positive. So the antibodies from the mother go on into the fetal circulation and they destroy the red blood cells of the baby. So if the red blood cells are destroyed, then obviously the baby will develop anemia. Then fetal anemia is also seen in parvovirus B19 infection. If the mother has this viral infection, this passes on to the baby, and a congenital parvovirus B19 infection then causes severe anemia in the baby. Some conditions of the placenta, like chorioangioma of the placenta, can also lead to polyhydramnios. One very important cause of polyhydramnios is also twin-to-twin transfusion syndrome or TTTS. In this, one twin receives more blood supply than the other twin. So the twin which is receiving more blood supply is known as the recipient twin, and this twin, obviously because it's getting more blood supply, so it's larger in size and it produces more urine, and so there is more associated amniotic fluid. In 50 to 60% of cases of polyhydramnios, we do not find a cause, and these cases are then labeled as idiopathic polyhydramnios. But before we label a case as idiopathic, we need to first exclude all the causes for polyhydramnios. So basically the diagnosis of idiopathic polyhydramnios is a diagnosis of exclusion. Then the million-dollar question is, how do we diagnose polyhydramnios? So on clinical examination, we suspect polyhydramnios in a woman if we find that her uterine height or her abdominal height is more than the period of gestation of pregnancy. Now suppose normally by 20 weeks of pregnancy, the abdominal height or the fundal height of the uterus should be somewhere around the navel of the woman. Now if we find this height to be more than that, then we suspect that it can be a case of polyhydramnios, and an ultrasound scan is advised for this woman. So the final diagnosis of polyhydramnios is made on ultrasound scan. So there are two methods by which on ultrasound we can say that this is a case of polyhydramnios. The first method is measurement of the single deepest pocket. So in this we measure the deepest pocket of amniotic fluid which is seen on ultrasound, and normally this should be less than 8 centimeters. If this single vertical pocket or the single deepest pocket is more than 8 centimeters, then this is labeled as a case of polyhydramnios. We can also grade the severity of polyhydramnios depending on the depth of this pocket. So if the single vertical pocket is between 8 to 11 centimeters, then this is a case of mild polyhydramnios. If between 12 to 15 centimeters, moderate. And if the single vertical pocket of LICA is more than 15 centimeters, then the case belongs to the severe polyhydramnios. The second method of measurement of amniotic fluid on ultrasound is amniotic fluid index or AFI. In this we divide the mother's abdomen into 4 quadrants, and in all the 4 quadrants we measure the single vertical deepest pocket and then we add them together. So normally this should be less than 24 centimeters. More than 24 centimeter means polyhydramnios, and again we can grade this according to the depth of the pockets, or we can grade it according to the AFI index. If it is between 24 to 29.9, that is less than 30 centimeters, then it's a case of mild polyhydramnios. Between 30 to 35 is moderate, and anything more than 35 centimeters AFI is labeled as severe polyhydramnios. Now that we have a diagnosis of polyhydramnios, now do we need to investigate this pregnant woman further? Would this woman require more tests? So the answer to this is a definite yes. Like I said, that there are many causes for polyhydramnios, and once you have diagnosed polyhydramnios on ultrasound, you need to find the cause for this. So the most common cause associated with polyhydramnios is maternal diabetes. So now we need to do a 75 grams oral glucose tolerance test on this pregnant woman if it has not been done earlier. And if the test has been done earlier but it's been done more than 1 month before, then we will need to repeat the test. Then because some congenital infections, especially syphilis, the TORCH group, that is mainly toxoplasmosis and CMV, as well as parvovirus B19, they can lead to polyhydramnios. So we need to test the pregnant mother's blood for these infections. Next thing to do is a targeted ultrasound scan. Now we know that many common abnormalities of the baby can lead to polyhydramnios. So now we really need to look at the abnormalities in detail. We have to exclude any of these abnormalities which can lead to polyhydramnios. So you look for anencephaly, you look for cleft lip, cleft palate, you see the gastrointestinal tract of the baby in detail to make out any esophageal or duodenal atresia, any tracheoesophageal fistula or diaphragmatic hernia. Then in twins especially, you look out for twin-to-twin transfusion syndrome, see the placenta to rule out any chorioangioma, see for the baby's weight because macrosomic babies can be associated with the increased amniotic fluid. Then we look for soft markers of any genetic abnormality like trisomy 21 and trisomy 18. If we find any soft marker for genetic abnormality, then we need to do genetic testing also in these pregnant women, and studies have shown that almost 5% cases of severe polyhydramnios are associated with a genetic abnormality in the baby. Neurological dysfunction of the fetus can also be assessed on ultrasound by seeing the movements of the baby. If you feel that the movements of the baby are less, so this could actually point out towards a neuromuscular dysfunction in the growing baby. What are the complications associated with polyhydramnios? What should we be alert for? So these complications can be either during pregnancy, or they can be during labor, or they can be fetal complications. So during pregnancy, women who have polyhydramnios can even have hypertensive disorders. That means their blood pressure can be high during pregnancy. The baby can be bigger in size or macrosomia. There are more chances of malpresentation because of excessive amount of fluid. The fetal head, which is supposed to occupy the lower end of the uterus, that doesn't happen, and the baby, because of the fluid, so much fluid inside the uterus, keeps on moving. So the presentation generally is not vertex in them, and they can have malpresentation in the form of breech or even transverse lie. Such women can also go into preterm labor, and they can also have premature rupture of membranes. The membranes which are to rupture, that is the water bag, is supposed to rupture at onset of labor, but in women, because of so much amniotic fluid, women who have polyhydramnios can have premature rupture of membranes. Now, once a woman has rupture of membranes, there is always danger of cord prolapse. That means that the cord of the baby can come out of the uterine cavity. There is also danger of placental abruption. What happens is that because there was so much fluid in the uterus, and suddenly now that fluid is rushing out, so the placenta tends to separate from its normal place. So this is known as placental abruption. So this is also very common, especially once the water bag has ruptured. Then these women also have more of labor dystocia. They have increased chances of cesarean. Now, why more cesarean in these women? Because the baby is big, there can be labor dystocia, there is malpresentation, there can be cord prolapse, and there can be placental abruption. So there are so many reasons for which these women can land up in a cesarean. Then even after delivery of the baby and placenta, there can be postpartum hemorrhage. Now, because of chronic overdistension of the uterus because of increased fluid, after delivery, the uterus is not able to contract properly, and this leads to increased bleeding after delivery. So these women tend to have more chances of postpartum hemorrhage. Now such babies also have higher respiratory morbidity. They are not able to breathe properly, and more of respiratory distress syndrome as well as transient tachypnea of newborn, TTN as we call it, is seen more in such babies because they have more fluid in their lungs. And when they are born, their lungs are not able to expand properly, and so they have trouble breathing, and more admissions in NICU are then seen for these babies. The 5-minute Apgar score, which tells us about the well-being of the baby who has just been born, that too is low in such babies. So the problem of polyhydramnios does not only extend throughout pregnancy, but it can cause problems during labor, after labor, as well as for the baby who's just been born. So then when we know it can cause so many complications, then how do we manage women who have polyhydramnios? Management of polyhydramnios would depend upon the underlying cause and the severity of polyhydramnios. Now, mild cases of polyhydramnios, generally these women have no symptoms and no treatment is required for such women. Now, women who have severe polyhydramnios, these women generally would have symptoms of abdominal pain or discomfort. Obviously, when your abdomen is so much distended with excessive fluid, then you are going to have abdominal pain, you might have abdominal discomfort, might go into even preterm labor, or might have premature rupture of membranes. So, and also they, at times complain of shortness of breath. They are not able to breathe properly because their abdomen is so much distended. Now, for these women, obviously we need to give them some symptomatic relief. So that can be done through amnioreduction. What we do in this is basically we drain the amniotic fluid using a needle. So this is done under ultrasound guidance. The wide bore needle is, it is put inside the mother's abdomen while doing the ultrasound, and then about 1.5 to 2 liters of fluid, as much fluid so as to make that woman comfortable, that much fluid is drained, and so her symptoms, she gets relieved of her symptoms. But the problem is that amniotic fluid is going to reform again. So generally repeated procedures might have to be done. And also this procedure has got its own set of complications in the form of, maternal infection, and then this can lead to premature rupture of membranes as well as preterm labor itself. So not really a very foolproof method, but to make the mother more comfortable, at times we have to resort to this. The second method which can be used to decrease the amount of amniotic fluid is in the form of a drug called indomethacin. So this drug, what basically does is that it decreases fetal urine output, but we do not advocate this drug after 32 weeks of pregnancy. So this drug is to be used only before 32 weeks of pregnancy and for a short time. Generally, we only recommend it for 48 hours or so, especially if a woman is going into preterm labor because of increased LICA, then we prescribe this tablet, but only for 48 hours and only in women who are less than 32 weeks pregnant. Because if given to women who are more than 32 weeks pregnant, it is associated with many complications in the developing baby. So what does polyhydramnios mean to you? Should you worry too much? No. Please don't worry too much. Don't panic if you have polyhydramnios. It means that you need to relax more. Find ways to relax. You need to rest more. You would have more frequent antenatal visits and you'll have more frequent ultrasound scans to see for the volume of amniotic fluid and the fetal growth. You need to stay more alert. Anytime if you have abdominal pain, shortness of breath, or your water bag ruptures, you should report to the hospital immediately. So be aware and be safe.